Usually, when we talk about a medical emergency, the sight of blood is like the ultimate red flag.
Oh, absolutely. It's the alarm bell. I mean, it means a physiological boundary has been breached.
Right, vital resources are just being lost.
Yeah.
And the immediate visceral instinct of every doctor in the room is to, well, stop it.
Yeah, it's a very primal binary reaction that's built into medical training. Blood belongs on the inside, maintaining pressure and delivering oxygen.
Exactly.
If it's on the outside, we have a crisis, one that demands immediate mechanical or chemical intervention.
Well, for you listening, today we are tracing the journey of a woman's blood from that frantic, life-saving necessity in the delivery room all the way to a highly controversial, commercialized lifestyle treatment for brides.
It is quite the journey, yeah.
It really is. And to do this, we're pulling from a pretty diverse stack of sources. We've got the strict clinical guidelines from the Royal College of Obstetricians and Gynecologists, the RCOG. We're also dissecting medical reviews on regenerative therapies from Naledi. And we've got a recent Times of India report looking at this wild new bridal wellness trend, along with insights from clinical specialists.
It's a lot to cover.
It is. So our mission today is to explore this massive paradigm shift. We are looking at the spectrum of autologous blood use, meaning, blood that comes entirely from the patient themselves.
If we connect this to the bigger picture, we are watching a biological resource completely transform. We are moving from viewing blood as just this static fluid that transports oxygen to viewing it as essentially a highly concentrated pharmaceutical.
A pharmaceutical that you manufacture inside your own body.
Exactly. It's a transition that tells us a lot about the cutting edge of regenerative medicine, the pitfalls of commercialization, and really the human body's incredible capacity to heal itself.
Okay, let's unpack this. Because to understand how we eventually arrive at luxury bridal clinics, we have to start with the sheer desperation of losing blood in women's health.
Right, the delivery room.
Yeah, let's look at the delivery room. According to the RCOG Green Top Guideline number 47, obstetric hemorrhage, which is severe bleeding during or after childbirth, is not some rare anomaly.
No, not at all.
It remains the third leading cause of direct maternal deaths in the UK. We're talking over 4,000 severe cases annually.
And that scale of the problem dictates why the protocols are just so rigid. When a patient is losing massive volumes of blood, her circulatory system is literally collapsing.
Wow.
So the RCOG is very specific about identifying vulnerabilities early, like anemia. In pregnancy, anemia is defined as a hemoglobin level less than 110 grams per liter in the first trimester.
Right, and then I saw it drops down to 105 in the second and third trimesters.
Exactly. Because if a patient starts with low reserves, a hemorrhage becomes lethal much, much faster.
And when that severe hemorrhage actually happens, reading the RCOG guidelines feels less like reading a medical textbook and more like, I don't know, studying the playbook for an elite Formula One pit crew.
That is a great way to put it.
Every single second is tracked. But it's not just a matter of opening a fridge and grabbing whatever blood is there. Right. They have this strict 3-day rule for cross-matching.
Yes, the 3-day rule.
A blood sample from the mother must be less than 3 days old to be used. I had to read that twice. I mean, why wouldn't a blood type from a week ago still be valid? Your blood type doesn't change.
Well, your blood type doesn't change, but your immune system's memory definitely does.
Oh, interesting.
Yeah, pregnancy is this unique state where a woman's body is carrying a genetically distinct entity. Sometimes fetal blood cells cross into the maternal circulation, or maybe the mother had a previous minor transfusion.
Okay, so what happens then?
These events can trigger the mother's immune system to unexpectedly produce new antibodies against specific red cell antigens. The immune system is highly dynamic, constantly updating its threat database.
It's learning in real time.
Exactly. So if you use a blood sample from a week ago, it might not show an antibody that developed yesterday. And if you transfuse blood containing that specific antigen, the mother's immune system will attack the donor blood.
Which causes a potentially fatal hemolytic reaction.
Right. The snapshot of her immune status must be incredibly fresh.
That makes perfect sense. So in a massive hemorrhage where they don't even have time to do that 3-day screen, they immediately push group O RHD negative red cells, the universal donor.
Yeah, you just have to get something in there.
But here is where the pit crew analogy really clicked for me. If a car is leaking oil on the track, you don't just pump more oil in. You have to plug the leak.
Precisely.
Just pumping red blood cells into a bleeding woman won't save her because red cells don't clot.
They just carry oxygen. If you only replace red cells, you are actually diluting the patient's remaining clotting factors. She will just bleed out faster.
God, that's terrifying.
It is, which is why the RCOG major hemorrhage protocol dictates a highly specific ratio to rebuild the blood's integrity on the fly. For every 6 units of red cells, the medical team administers fresh frozen plasma, or FFP.
And that's at a dose of 12 to 15 milliliters per kilogram, right?
You got it.
So the FFP provides the fluid dynamics, but they also push cryoprecipitate. And this is the actual concrete being poured to fix the track, yeah.
That's a good analogy. Cryoprecipitate is rich in fibrinogen. That's the protein that forms the physical mesh of a blood clot.
Right, and the protocol specifically targets keeping the patient's fibrinogen levels above 1.5 grams per liter.
They are chemically reconstructing the patient's capacity to heal while the trauma is literally still occurring. The logistical challenge of acquiring, matching, and balancing donor blood is just immense.
I can imagine.
And this immense difficulty, this life and death struggle to replace lost blood, forced the medical community to ask a pretty radical question. What if we didn't rely entirely on the blood bank?
What if we could rescue the blood the patient is actively losing? Which brings us to a fascinating procedure in the RCOG guidelines called intraoperative cell salvage, or IOCS.
Right, IOCS.
So if a woman is having a high-risk cesarean and is expected to hemorrhage, they set up a specialized machine right there in the surgical field. As she bleeds, a suction device collects her blood.
It's pretty incredible technology.
Yeah, the machine then washes it, filters out the amniotic fluid and cellular debris, and reinfuses her own red cells back into her body in real time.
It completely bypasses the need for donor blood, which eliminates the risk of an immune reaction to foreign antigens. But, it does introduce different risks that have to be managed.
Like what?
Particularly for Rhd-negative mothers. The machine might accidentally reinfuse some of the baby's Rh-positive red cells into the mother's bloodstream. We call that a fetal-maternal hemorrhage.
And if those baby cells enter the mother's bloodstream, her immune system will recognize them as foreign, build antibodies, and then actively attack her next pregnancy.
Which is why the protocol mandates testing for fetal-maternal hemorrhage 30 to 40 minutes after the reinfusion, and then they administer anti-D immunoglobulin.
Anti-D?
Yeah, anti-D acts like a stealth squad. It finds and neutralizes those fetal cells before the mother's immune system even notices they are there.
So it prevents her from forming those dangerous antibodies.
Exactly.
It's an incredibly delicate biological dance. But the success of intraoperative cell salvage proved a revolutionary concept. We can safely extract, manipulate, and return a patient's own biological material to solve a major physical trauma.
It really is a game changer.
And that leap, realizing that our own blood holds the key to our recovery, paved the way for regenerative medicine. We move out of the delivery room and into the science of platelet-rich plasma, or PRP.
The Naledi review breaks down the mechanics of this leap beautifully. Platelets are the tiny, disc-shaped cell fragments in our blood responsible for the first stages of clotting and tissue repair.
Right.
With PRP therapy, medicine is deliberately isolating those specific fragments and just massively concentrating them.
The centrifuge process they use to do this is fascinating. Imagine a bottle of unhomogenized milk. If you let it sit, the heavy liquids sink to the bottom, and the rare, valuable cream floats to a distinct layer.
That's a really good visual.
So when they draw a patient's venous blood, they put it in a centrifuge for a soft spin. The heavy red blood cells sink like pebbles to the bottom of the tube. The lighter liquid plasma stays at the top.
And right in the middle, a thin, cloudy layer forms. That's called the buffy coat.
A buffy coat?
Yeah, and that buffy coat is the biological gold mine. It contains the majority of the patient's leukocytes, the white blood cells that fight infection, and the platelets.
Okay, so then what's the second step?
For the second step, the lab extracts that buffy coat along with a small amount of the adjacent plasma and runs hard spin. This faster rotation forces the platelets to compress into a dense pellet at the very bottom.
Oh, wow.
They discard the excess fluid, mix that pellet with a tiny volume of plasma, and the result is PRP.
The Naledi review notes the resulting plasma has a platelet concentration up to 335 times greater than what is normally flowing through your veins.
It's a huge concentration.
I have to admit, when I first read this, it sounded a bit like science fiction. We're extracting the body's first responders, multiplying their density by over 300, and injecting them directly into a failing tissue.
I get that, but the mechanics of how those concentrated platelets interact with damaged tissue are grounded in very solid biology. When injected, these platelets are often activated, sometimes by adding calcium chloride or simply by coming into contact with the patient's own damaged collagen.
Right.
This activation causes the platelets to burst open and release their alpha granules. These granules are basically storage sacs packed with over 30 bioactive proteins, growth factors, fibrin, fibronectin, and vitronectin.
Let's unpack fibronectin, because it's not just a buzzword. It acts like biological glue, right?
Yeah, exactly like a glue.
It cross-links proteins together to build an actual physical scaffold, so new cells have a structure to crawl across and repair the tissue.
It builds the framework, while the growth factors act as the biological construction foreman. They promote angiogenesis, which is the sprouting of brand new blood vessels from existing ones.
Which increases blood flow and oxygen to the area.
Exactly. They also stimulate local fibroblasts to start churning out new collagen and extracellular matrix.
Okay, so that's the underlying biological machinery. But what does this actually look like in practice for women? The Naledi review focuses heavily on using this concentrated healing serum for chronic quality-of-life issues that traditional surgery struggles with.
What's fascinating here is how it's being applied to things like stress urinary incontinence, or SUI.
Right, SUI.
SUI involves involuntary urine loss during physical exertion, coughing, laughing, exercising. It affects millions of women and fundamentally alters how they live. For years, the surgical gold standard has been the mid-urethral sling,
where a surgeon implants a synthetic polypropylene mesh to physically support the urethra, kind of acting like a hammock.
Yes, but vaginal tissue is incredibly dynamic. It expands, contracts, and constantly sheds and regrows mucosal layers. A rigid synthetic plastic mesh doesn't do any of those things.
Which is why the complication rates can be so devastating.
Very devastating.
This synthetic mesh can literally erode right through the vaginal wall, or cause chronic, debilitating pain syndromes because it's a permanent foreign body rubbing against sensitive tissue.
Right. So rather than forcing a mechanical fix with a synthetic object, doctors are utilizing PRP for a biological fix. By injecting PRP directly into the tissue surrounding the urethral sphincter, the growth factors stimulate the regeneration of the muscle tone and the supporting ligaments themselves.
That's amazing.
The review highlights a prospective study of women with severe intrinsic sphincter deficiency who received 4 monthly PRP injections. The outcomes were remarkable.
Yeah, a 50% success rate, right?
Exactly. With nearly 46% of patients achieving complete dryness immediately and the effects lasting up to 12 months.
12 months of relief generated entirely from your own blood. That's huge. And we see similar applications for dyspareunia, which is the medical term for chronically painful intercourse.
Yes, and we looked at clinical insights from Dr. Nadia Yusri, a consultant in regenerative gynecology. Dyspareunia has multiple root causes.
Like what?
Well, it can stem from the massive drop in estrogen during menopause, which stops the mucosal lining from producing glycogen, altering the pH and literally thinning the tissue out. Or it can come from trauma, like poorly healed episiotomy scars after childbirth.
Okay, that makes sense.
It can also be caused by chronic autoimmune conditions like lichen sclerosis. The immune system mistakenly attacks the skin of the vulva, causing it to become incredibly thin, white, and prone to severe tearing, almost like wet tissue paper.
Oh, that sounds awful. And traditional treatments like topical steroids or estrogen creams have significant limitations.
They really do.
This is where Dr. Yusiri's protocols combining PRP with energy-based treatments caught my attention. Doctors use fractional CO2 lasers or radiofrequency wands on the vaginal tissue before applying the PRP.
Which is a brilliant combination.
At first, using a laser to treat painful, thinned-out tissues sounds kind of counterintuitive. But the laser vaporizes tiny, microscopic columns of tissue. It's a controlled, intentional injury.
It is essentially ringing the biological alarm bell. The body senses this micro damage and immediately sends distress signals to initiate repair.
Right.
When the doctor follows up by injecting that 300 times concentrated PRP directly into the laser-treated area, they are flooding a highly receptive signaling environment with an overwhelming supply of growth factors and biological scaffolding.
So the angiogenesis brings new blood vessels, restoring oxygen and reviving the natural lubrication glands.
It's literally reversing tissue atrophy at the cellular level.
If this treatment is relatively low risk because it's autologous, meaning your body will never reject its own blood, and it avoids the severe complications of synthetic mesh, the patient demand makes total sense.
Oh, definitely.
But history shows us that whenever clinical promise meets soaring consumer demand, the market finds a way to exploit it.
Yes. The transition from a medical intervention aimed at severe tissue atrophy or incontinence to a commercialized product happens remarkably fast when the barrier to entry is basically just a centrifuge and a syringe.
Here's where it gets really interesting. Which brings us to the Times of India report, detailing how this exact science has spawned a highly controversial commercial trend.
The O-Shot.
Yeah. In the aesthetic and commercial market, PRP for sexual wellness has been rebranded as the O-Shot, short for orgasm shot. And right now in India, it is being aggressively marketed directly to brides.
The framing in these marketing campaigns shifts entirely away from pathology. It is no longer about healing lichen sclerosis or avoiding mesh erosion.
Right. It is being positioned purely as a lifestyle enhancement.
Exactly.
The report describes clinics pitching this vaginal injection alongside destination weddings in Udaipur, designer Manish Malhotra lehengas, and pre-wedding gold leaf facials. They are promising to enhance the honeymoon experience.
It's wild.
I have to step back here because injecting a highly concentrated experimental biological theorem into an incredibly sensitive area just days before a honeymoon seems biologically illogical. You risk swelling, bruising, or nerve irritation exactly when you don't want it.
And the medical community on the ground is raising the exact same alarms. Dr. Tripti Raheja, a director of obstetrics and gynecology in Delhi, highlights the psychological trap here.
Right. Female sexual dysfunction is notoriously complex.
Very. For a bride, issues with intimacy might be rooted in extreme wedding planning stress, fatigue, hormonal fluctuations, or relational anxiety with her partner.
A localized injection of concentrated platelets cannot biologically override a bride's psychological stress or relationship hurdles. It is a biological tool for tissue regeneration, not a magic wand for emotional intimacy.
That's the crux of it. Dr. Juhi Jain, another leading gynecologist, points out the stark regulatory reality. The O-Shot is not FDA approved for the treatment of sexual dysfunction.
Even though the risk of an allergic reaction is nearly zero because the blood is autologous.
Right, but the procedure completely lacks robust, large-scale clinical evidence to prove it works as a universal, quick-fix enhancement for healthy individuals.
She notes that while severe complications are rare, introducing a needle into that area carries universal risks: infection, localized pain, swelling, and temporary altered sensations.
We must also acknowledge the nuance within the medical literature itself, though. The Cellular Medicine Association, founded by Dr. Charles Reynolds, who originally invented and trademarked the O-Shot protocol, maintains that there's valid science here.
Yeah, I read that. A recent randomized controlled trial published in the prestigious Green Journal did show that specific PRP injections into the anterior vaginal wall improved sexual function scores in women experiencing genuine dysfunction.
The problem, as Dr. Reynolds himself has pointed out in various medical forums, is that the commercial market is highly unregulated. Thousands of clinics use the term O-Shot generically.
They aren't following the strict trademark protocol for how the PRP is centrifuged, what layers are extracted, or exactly where it is injected.
Exactly. A bride might walk into a medical spa, pay a premium, and receive a poorly prepared generic plasma injection under a flashy marketing name.
So the commercial application is dramatically outpacing the clinical proof.
Completely. We have incredible data for stress urinary incontinence. We understand the regenerative mechanics of the buffy coat. But marketing an investigational cellular therapy as a guaranteed cosmetic upgrade for a wedding exposes patients to unnecessary physical and financial risk.
For you listening, it's a lot of complex biology and market forces to weigh. We started this deep dive in the high-stakes, hyper-regulated environment of an obstetric emergency.
Where every drop counts.
Right. We saw how strict protocols, like the 3-day cross-matching rule and perfectly balanced ratios of fresh frozen plasma and cryoprecipitate, use blood mechanics to literally pull women back from the brink of a hemorrhage.
We saw how the desperate need to save blood led to intraoperative cell salvage, proving we can recycle a patient's own biology.
And we followed that realization into the centrifuge, where the buffy coat is extracted to treat devastating conditions like incontinence and severe painful intercourse, offering biological healing over synthetic surgical meshes.
And we finally landed in the unregulated frontier of commercialized medicine, where the profound promise of those concentrated platelets is bottled up and sold to brides as a honeymoon enhancement.
Completely ignoring the deeper psychological and hormonal complexities of human sexual health.
It forces us to confront a fascinating regulatory puzzle. As medicine continues to shift toward using our own biological material as the primary drug, where the pharmacy is quite literally running through our veins, how will regulatory bodies like the FDA or the RCOG ever properly regulate a treatment that relies entirely on an individual's unique, unpatentable blood?
You can standardize a synthetic chemical pill, but you cannot patent or standardize a patient's own platelets.
Exactly. It's a whole new frontier.
Well, thank you so much for joining us on this deep dive. Keep questioning the science behind the headlines. Always ask exactly what's inside the syringe. And remember, sometimes the most powerful, complex medicine we have has been flowing inside us all along. See you next time.